Hello. This is going to serve as a brief introduction to the ultrasound curriculum at CMSRU. The goal here today is to give you guys a brief idea of what precisely you're going to be doing over the next few years, if you're a first year, and if you're a second, third, or fourth year, to give you an idea of what your portion of the curriculum will look like. My name is Sarab Sodhi, and I direct the curriculum. So let's start off with a couple of disclaimers. So there is no reason for the sandpuppy eyes. I promise even those of you who are later on in the year and later on in your training will get a whole bunch of exposure to point-of-care ultrasound. That's the way we've designed this. A couple of other disclaimers I should make out. So this is not going to make you a better test taker. That's not what this is designed for. This curriculum is simply designed to make you a more competent physician with the goal of making you much more comfortable taking care of patients and integrating ultrasound into your practice. That, of course, is predicated on the assumption that using an ultrasound makes you a keener clinician and a more capable doctor, which is something I believe. The other thing I will make the point of is none of you are truly going to be Doogie Howser. If those of you who don't know who that is, you might be better known as Barney Stinson from How I Met Your Mother. But the distinction here is that it gives you additional data points to use at the bedside. It can't replace your clinical reasoning skills. It can't replace your history and physical exam skills. It won't take away from your ability to get a history from the patient and make a differential. But what it can do is give you immediate bedside testing capabilities that you can use, that you're not reliant on someone else coming in to do for you, and can help you narrow that differential diagnosis or do procedures more safely, or, rule things out, rule things in, all of that. The final disclaimer is my bias. So as you can see from here, my job is to teach ultrasound, which means my bias is that ultrasound is pretty good. I do try pretty hard to ensure that I don't overly lean into that bias, and I do try pretty hard to ensure that I'm teaching you along the way that there are some times where point-of-care ultrasound is a distraction or not helpful or doesn't add any value to the patient's care. The other point I will make to you is I'm an emergency physician. So my other bias is that I tend to view a lot of things through this lens. I again try to keep a generic view on everything, however that doesn't always happen. So we already sort of talked about why we're doing it, but I will make the point that point-of-care ultrasound makes you, in my opinion, a better clinician, makes you think more deeply about what's going on with the patient and how best to get them the help they need to get whatever is going on sorted. So with all that said, the other point I will make to you is, in addition to my word and the fact that I'm saying that this is true, you should consider the fact that there's a good amount of evidence. There's evidence in internal medicine, and this is designed for the internal medicine physicians and internal medicine settings. There is other help in patients with undifferentiated shock, undifferentiated dyspnea in the emergency department, CHF, and along the way it'll give you far more information. So here you can see various pathologies ongoing, which have decided to act up, but here you can see that there's a large pericardial effusion. Here you can see there's a big dilated right ventricle. So, in your very first year, you'll get to do a few things. First and foremost, we're going to walk you through a procedural session. You're going to learn how to do point-of-care ultrasound for placing ultrasound-guided IVs and for doing nerve blocks. Now, we're leading with this because this is essentially a head fake. I'm not expecting you to learn how to use any of this, but I will teach you the basics of physics, the basics of probe handling, probe placement, depth gain, all of these fancy words. You will learn all of that by putting pointy objects in, gelatin models. Again, the expectation is not that you will be confident or capable at any of these processes, but as you know, repetition leads to success. So the goal is going to be to repeat the training over and over until it feels comfortable. So this will be a very first training. The next session you'll do will be in your MSK block, where we'll talk through a patient with leg pain as the differential, and then we'll talk about the various anatomy of the knee and what all can be ultrasounded. So this will be done with small group sessions like this with a physician instructor and then a couple of you guys and a standardized patient who's being paid. We have really nice fancy new ultrasound machines that project on a big screen, so more than you don't have to stare at the tiny screen alone. In the second year, it gets a little bit more intense. So in the second year, we start off with cardiology. A point to be made about all of my teaching sessions is I don't believe in general in lecturing at you guys. The lecture we did in person for the first years is probably the extent of in-person lecturing you get, other than bedside hands-on education. So to supplant that, you get a watch list, a playlist of things to watch. Essentially, you get sent an email with a playlist attached, and the videos are 10 to 15 minutes in length at most. The expectation is you watch those videos before you come in. And again, in the second year, you do that same small group, in-person, hands-on teaching session. The expectation there being that you will get sort of a basic introduction to the anatomy, the physiology, and we will briefly talk about the pathology, but we're not going to dive into it, and you'll see why momentarily. So that's your first session. You'll then proceed to do essentially the same format for all these following sessions. We will go through gallbladders, we'll go through pregnancy ultrasounds now that we have high-fidelity simulators that can allow for that. We'll go through renal ultrasound, and new for next year is endocrine ultrasound, as well as lung ultrasound. Once we've done all of that, you'll be preparing to transition to your clinical year. And in your clinical years, before you start your third year, you'll do an orientation and a course to get you comfortable. As you're doing that, we will again revisit that thing we did in the very beginning of first year. You'll get to practice ultrasound IVs in small groups, and if you are unlucky, like Dr. Adorno here, who was an intern and is now my fellow, you'll get to place one on me. I have matured somewhat since then, so I'm less likely to let people stab at me. Now, after that, you'll jump into the core curriculum, so to speak. So in the third year, it gets a lot more involved. So you will basically get a much longer series of playlists. We talk about, this was an introductory video I put together for this past year, explaining what the sessions are because they were brand new. You'd get an introduction to sort of the philosophy of point-of-care ultrasound. You'd get an introduction to how to use the ultrasound and basic probes and knobs. And, these will basically be in every playlist going forward, or some variant of them, to ensure that if you guys are uncomfortable, you can go back and watch this over and get more comfortable with the philosophy or how we do it. Then you'd come back and you'd watch essentially the same videos you watched as a second year with some changes, where you do the basic windows in anatomy, you do a pathology section. For cardiac, that's one of the few we've done this way because of the density of the material. Then we'd move on and do the same thing in lung ultrasound. You'd have to go through sort of the how to do the lung ultrasound itself and then pathology again. So once you've prepared for the session and come in, you'd split into 3 groups, and for 3 hours, you'd rotate through these following 3 stations in whatever order you're rotating. First station would be standardized patients. So you'd come through and you'd practice, in this example, say cardiac ultrasound on a standardized patient. You'd have physician instructors, they'd be walking you through the entire process, it would work great. In the second hour, you'd go through our high-fidelity simulators. So there you can see Bob, and you'd be ultrasounding Bob with a high-fidelity simulator creating pathology. Now on the high-fidelity simulators, your instructors can call up whatever pathology they'd want. Sometimes they will be kind and leave the actual label of the pathology up. Other times they won't. I generally tend to have them make sure there's no labels, because unfortunately patients don't tend to come with labels either. And you'd get to figure out what's wrong with the patient. For the third hour, you would do one of 2 things. You'd either do a procedure lab, or you would come in and do medical decision-making cases. So for the medical decision-making cases, typically I run those. You'd come in and we'd have a case on the screen with a clinical vignette. You'd have a number of your colleagues in the room. We'd all be going over sort of the history of the presentation and then what testing you could do. And the way we designed this in this past year was to have them walk through the beginning to the end of a clinical case with all the ancillary tests that would involve, to make sure you guys have a good exposure to that. And that would be the extent of it. Alternatively, some sessions come with a procedure lab, and on the procedure lab you'd come in and have a couple of instructors walking you through the basics of arthrocentesis, ultrasound guided IV placement, central line placement, potentially some other procedures as well. Okay, so that gives you a brief idea of sort of what we're thinking and why. Now, the sessions that we would cover throughout the third year would include a dedicated cardiac session, dedicated pulmonary session, a dedicated abdominal session, which would cover gallbladder, renal, etc. We'd cover a dedicated OB session. Renal will be included in the previous one. We'd cover FOST exams as well. We'd cover how to do aortic ultrasound, and then DVT ultrasound as well. Now, finally, in the fourth year, there is a system set up that would allow you guys to get an introduction, a reintroduction, I should say, to point-of-care ultrasound with cardiopulmonary ultrasound in the ICU run by intensivists. We are attempting to develop a fourth-year emergency medicine required experience, but there's always the option of getting that experience when you're working clinically, but the goal is to give you guys a required experience as well. Also, for those of you who are particularly so inclined, there is the option of doing an emergency medicine ultrasound elective. Now, the goal with these fourth-year rotations would be they would basically look similar to the third-year rotations, but be much more focused. We'd be talking through, doing, say, for example, in this example, doing point-of-care echo, using SPs, using high-fidelity simulators again. If you have any questions about this introduction, feel free to send me some emails.